Hey there, and welcome to this explainer. I'm absolutely thrilled to have you with us today because we're tackling a topic that is just massively important, but also incredibly confusing: hypertriglyceridemia, or in plain English, high triglycerides. We're going to cut right through all that loud marketing noise you hear and look at exactly what the clinical data actually says about dietary supplements for this condition. Let's get into it. So, I want to kick things off by posing a pretty critical question to you. Are your supplements saving your heart, or are they actively harming it? Seriously, think about it. The supplement aisle at your local store is just totally saturated with misleading advice. You might actually be taking something right now, hoping it'll improve your lipid profile, without realizing it has hidden dangers or even severe drug interactions. Well, today, we're going to fix that. Here's our roadmap for today. First, understanding high triglycerides. Second, the heavyweight, prescription omega-3s. Third, helpful adjuncts and fibers. Fourth, dangerous interventions to avoid. Fifth, ineffective options. And finally, number 6, the clinical synthesis. All right, section 1, understanding high triglycerides, the invisible threat. To set our baseline here, we've got to understand that plasma triglycerides act as a direct, quantifiable measure of the dangerous lipoproteins circulating right now in your bloodstream. And you actually face two very different physiological risks depending on your levels. On one hand, a moderate elevation that's between 150 and 499 milligrams per deciliter, well, that drives this slow, steady building of atherosclerotic plaque. But on the flip side, a severe elevation, which is defined as 500 or greater, triggers something entirely different. It can lead to the toxic, incredibly rapid tissue necrosis of acute pancreatitis. So it's a dual threat, right? And that dictates exactly how aggressive we need to be with treatment. Moving on to section 2, prescription omega-3s, the gold standard. Now check out the sheer volume difference between retail fish oil and true prescription-grade therapies. It's wild. A standard over-the-counter 1,000 milligram fish oil capsule usually contains a measly 300 milligrams of active EPA and DHA. So what's the other 70%? It's just inactive filler, saturated fats, or even potentially oxidized rancid lipids. To get a clinically effective dose using those retail bottles, you'd literally have to swallow 11 to 14 of those standard pills every single day. That massive pill burden is exactly why lipid specialists bypass standard retail products altogether. So the most crucial takeaway here is this exact number: 4 grams. Clinical guidelines from the American Heart Association specifically demand 4 grams per day of active EPA and DHA. When you actually hit that true pharmacological dose, you can see a massive 27 to 45% reduction in your triglycerides. That is a real game changer. But wait, there is a vital biochemical paradox you really need to understand. Omega-3 formulations are absolutely not all identical. Mixtures that contain DHA, like Lavazza, are fantastic at lowering triglycerides, sure, but they can actually inadvertently spike your bad LDL cholesterol. Not great. Conversely, an EPA-only formulation, like icosapent ethyl or Vascepa, lowers those triglycerides without elevating your LDL. So if your ultimate goal is to prevent cardiovascular disease, protecting your overall lipid profile with an EPA-only agent is, without a doubt, the superior pharmacological choice. Okay, section 3. Adjuncts and fibers. These are our moderately helpful tools. First up in this tier is berberine. This is a highly potent plant alkaloid that essentially acts as a multi-target metabolic agent. What it does is it actually upregulates your liver's LDL receptors, extending their lifespan, which effectively pulls those circulating atherogenic lipids right out of your blood. It consistently lowers triglycerides by about 25 to 55 milligrams per deciliter, making it a stellar option for folks with insulin resistance. But, and this is a big but, I have to heavily caution you. Berberine is a strong inhibitor of the CYP3A4 enzyme pathway, which is the main system your liver uses to clear out other drugs. So that gives it a very high potential for some really dangerous interactions with statins and blood pressure meds. Clinical oversight is absolutely mandatory here. Next, we have pantethine, which is a remarkably safe alternative. It's actually a naturally occurring derivative of vitamin B5. By increasing intracellular coenzyme A, it safely inhibits the fatty acid synthesis cascade in your body. Systematic reviews have shown it can reduce triglycerides by up to 32.9% after 4 months of sustained therapy. And the best part? It does all of this without causing any of the systemic toxicity we sometimes see with other B vitamins. Then there's good old psyllium husk. It's a classic, highly viscous, soluble fiber. It works by literally physically sequestering bile acids in your gut, which forces your body to pull cholesterol straight from the blood to make more.
Now, while it's fantastic for your broader lipid profile, I gotta warn you, you absolutely must take this with copious amounts of water to avoid bowel obstruction. And crucially, it has to be temporally isolated by a few hours from all your other medications. Otherwise, it's just gonna indiscriminately block their absorption, and we definitely don't want that. To round out our helpful tools, let's quickly synthesize these minor botanicals. CoQ10, curcumin, Nigella sativa, and fenugreek. They provide some excellent synergistic support. Fenugreek, in particular, has this potent dual action on both your glycemic and lipid pathways, making it uniquely suitable if you're struggling with diabetic dyslipidemia. And CoQ10 is an incredibly safe adjunct, especially if you happen to be experiencing statin-associated muscle symptoms. Though, to be fair, its direct triglyceride lowering is a rather modest 9 points. All right, let's shift gears. Section 4, Dangerous Interventions to Avoid. The dangerous imposters. First off, we have to debunk the niacin myth. High-dose niacin, or vitamin B3, looks absolutely perfect on a lab report, right? It raises your good cholesterol and lowers your triglycerides. But the massive HPS-2 Thrive trial proved that despite making the numbers look great on paper, niacin totally failed to reduce vascular events. Instead, it caused severe bleeding, life-threatening infections, and a highly significant increase in new-onset diabetes. Because of that, it is fundamentally ill-advised in modern practice. Next is L-carnitine, and I really want to walk you through this fascinating but honestly terrifying biochemical pathway. When you ingest concentrated L-carnitine supplements, the unabsorbed portion actually feeds your gut microbiome, which then converts it into a gas called TMA. Your liver then rapidly oxidizes that into TMAO. Well, TMAO is an incredibly potent molecular risk factor that aggressively promotes macrophage foaming, which is a key driver of arterial plaque, as well as calcification and massive thrombus formation. So any theoretical metabolic benefit you might get is just completely wiped out by these severe atherogenic and thrombotic risks. No way. And then we have red yeast rice. Look, it works, but I have to warn you exactly why it works. The active compound in it, monocolin K, is chemically and pharmacologically identical to the prescription drug lovastatin. So red yeast rice is effectively an unregulated statin. It carries the exact same risks of muscle myopathy and liver injury as the prescription stuff, but with wildly unpredictable dosing and a real risk of contamination with kidney toxins. Just stay away.
Moving on to Section 5. Ineffective options, the placebos. We can rapidly dismiss these placebos. Rigorous, double-blind clinical trials have proven that aged garlic extract and chromium have absolutely zero statistically significant effect on triglycerides. I mean, they might have other niche uses, sure, but definitely not for this. And coconut oil, that one is actively misguided. It actually just adds dangerous saturated fat calories to your diet without offering any significant triglyceride reduction compared to healthy unsaturated oils. Finally, Section 6, Clinical Synthesis, the big picture. All right, so here is your concrete, actionable hierarchy from this explainer. First things first, absolute perfection of your diet and lifestyle is the non-negotiable foundation. You have to start there. From there, demand prescription EPA, like icosapent ethyl, to reach that critical 4-gram threshold and totally avoid that retail pill burden we talked about. You can utilize safe, moderately helpful adjuncts like berberine and pantethine to mop up the rest, just always being mindful of those drug interactions, and absolutely banish L-carnitine, high-dose niacin, and unregulated red yeast rice from your regimen completely. I want to leave you with this provocative thought today. When you're managing high triglycerides, you really need to ask yourself, is the goal just to change a number on a lab report? Or is it to fundamentally prevent cardiovascular disease and improve your actual survival? The science is crystal clear on this. Don't just treat a piece of paper. Prioritize the interventions that have proven cardiovascular outcome benefits. Respect the biochemical pathways, and always, always look past the marketing hype. Thank you so much for joining me on this explainer, and stay focused out there.